Hi. Good morning, everybody. I know it was a pretty long day yesterday and dinner and all. I'm happy so many are here in early morning. So again, the morning sessions were particularly designed to go to the basics. If you see in the afternoon, we talked about a lot of cutting edge technology and difficult situations. While morning, I know a lot of people who like to. You always have to start from basics. And if you ask me, the first morning topic today is particularly close to my heart. Again, the way yesterday I said about catheterization, which is so critical, yet somehow we don't value it so much. But the morning topic is again something which is so critical, and yet at times we may not value so much. Yeah, Jaya. Sorry. Yes, please invite, please. ये तो मेरा morning introduction था. I'm not starting the talk yet. Yeah.
So we start the session now then.
Yes.
So may I request Dr. Girish Rajpal kindly chair the session, please. And I request Dr. Atullab Vajpayee to kindly occupy the chair on dais. Our first session is training workshop, getting there and retrievals, getting access to the aneurysm.
All right, thank you. And is Dr. Trilochan here? No, Abhi. I saw him. So when he comes in, I wanted him to be there as well. All right, great.
Which is close to your heart. I will not come in between. Good morning. So let's begin with this first topic, that is access to aneurysm.
Thanks, Atulab. Thanks a lot for coming in. And so, yes, again, access to the aneurysm means how we get to the parent vessel and sometimes even beyond the aneurysm. And to me, again, a lot of times we talk about flow diverters, and I'm very fond of them, great technology and newer bifurcation devices. But a lot of revolution has happened at basic level. The plain simple coiling which we used to do, the guide catheter, the micro catheter, the coils have dramatically changed. And sometimes this revolution is missed. And sadly, 70-80% aneurysm which we do are still by these methods, and they play a very critical role. Now, what I want to talk about access, we divided into two parts, and you see there are two talks about it. The number one is how we access to the aneurysm, all right, and how that means how we'll access the aortic arch, the ICA, and when suppose aortic arch, there were a very bad angle of CCA like this, or there is an aneurysm, this patient had MC aneurysm, and you've got a carotid loop looking like this. It's a very funny kind of loop. Or you have, this patient needed a flow diverter, and you had a CCA loop like this. What do you do in these situations? It is more important, as I said, than usually realized. Is the key in difficult case? I will say is the key in every case. If you don't have a stable high guiding catheter and access systems, your whole dynamics change. As I said yesterday, it's all physics. Your higher the system is, and the less of tension in the system, more control over it. And we like our guidings to be high, as high as possible, commonly in the petrous and cavernous IC in all our cases now. The times have changed where I will do it from IC. I go higher up because I think one of the reasons also is that we are treating small ruptured aneurysm most of the time, and I find it very comfortable with the high guiding. So what do we do usually in all our regular cases? We use a long sheath in all our cases. So last maybe 7-8 years, I haven't done an aneurysm case without a long sheath. It makes the guiding stable and everything. Usually we end up using Cook rabbit sheath 70 centimeters. Nothing is very cheap. Doesn't add to the cost. Other guidings which are maybe better long sheaths, but they are much more costly. Usually we'll take it over into the CCA over a Picard 5F, do our 3D and all, and then we change into place the guiding catheter. Guiding catheter can be distal access catheter on AVN or ANVI. When a straight anatomy, again ANVI is a cheaper choice. And usually, but again, I personally feel Indian arteries are more irritable. Maybe there are smaller vessels as well. So usually we'll prime them with NTG 50 to 100 microgram in every case. And then coaxially over a 4-4 distal access catheter, we'll take a 6F guiding catheter into the artery. And as I said, I say usually we're primed with antigens. This is what we do in all our cases. So this is what we'll end up doing. So you place a long sheath in the common carotid artery. When it's a very tall patient, one may switch to 18 centimeter neuron max. Okay, and then over a Terumo wire, and I don't know whether I can make out. You can see this is the tip of the 4-4 DAC, which goes right up to there with using a Terumo wire. And in this case, this is an ANVI, which we have placed right up to the cavernous level. So this is the system, this is the long sheath, and the ANVI, which is high up. And then, of course, anything you handle becomes much easier when you're working right from there, the less tension in this system and everything, and we can control the situation. What would we do when there is a bad arch? So usually we don't struggle with this system until you think you can take the Picard there. We go to the SIM catheter, SIM 2 or SIM 3, depending on the arch anatomy. And this is what we do. You take a SIM, you rotate it, you hook the carotid, you go into it. A lot of times what we use is Emplart's extra stiff for exchange. It's a good wire because I've always found very difficult. Okay, I will show you. Sometimes we take this into the ECA, but sometimes when it's not going in there, we'll just place an Emplart's extra stiff tip. It's a very stable wire, very easy to exchange while the Terumo jumps up and down. And then using the Emplart's, then you get a coaxially, you get a long sheath up, first a diagnostic catheter, and then a long sheath, and then you are in place, then everything is a different game. And as I mentioned, sometimes we'll take this SIM into the ECA if possible. So again, this was a bad arch. So again, a SIM catheter. Once the SIM has gone in, over the wire, it straightens off, and we have taken into the ECA there. And then again, we have placed the Emplart's wire and exchanged into a long sheath. Again, long sheath is also always taken coaxially over a DAC or a Picard so that it goes in easily, just not only the long sheath. So everything goes coaxially or triaxially, and then it becomes very, very simple. Personally, as I said, with Terumo and using SIM, I have always find it difficult to exchange. When the SIM curves form in the aortic arch, it tends to pull out the Terumo, at least in my hands. And then in this particular case, which had an anatomy down below like this and an anatomy above like this, once your long sheath is up there and stable, we were able to go through coaxially all of that and get this patient was planned for a flow diverter and get our guiding catheter right there. And now, of course, it's a different ball game in a very stable situation, and you can undertake it. So Emplart's extra stiff is very useful exchange. Whenever we do, there's a distal access catheter or a diagnostic catheter or a VO in the long sheath. It's just not only the long sheath. It makes the job much easier. What about loop like this? This is again a very bad angle of origin, and there's a curve in the common carotid. Again, we have used, in this case, we have used a Neuron Max. So whenever there are very bad angles, at times we like to use Neuron Max because Neuron Max is softer. It does a curve at the tips. It goes through these very bad angles much easier than Cook-Rabe. As long as relatively straightish anatomy, Cook-Rabe sheath, otherwise switch to Neuron Max. But when we use Neuron Max, we use 80 centimeter. Because Neuron Max, you can't take up high up into the ICA in these aneurysm patients, and we want sufficient length of the guiding which can go up to the cavernous segment or so. So this is what we have done. In this case, we have directly used Neuron Max 80 centimeter, and along with this SIM2, and SIM2 has been sent. Once we have hooked it, we have straightened the SIM2, and then we have taken the SIM2 wire into the ECA, SIM2 into the ECA, and Neuron Max over it. And then it's comfortable. At times, suppose SIM2 has gone, there still this is not tracking, Neuron Max is tracking. So what we do, we take out the Terumo wire, and then we place the Emplart's extra stiff wire in the catheter. You need not even take it out. And then the whole system is very stable, and you can track it up. So once any catheter has gone to the ECA, you can take out the wire, place Emplart's extra stiff into it, and then your guiding will go, your long sheath will go like a dream. It becomes much more easier. The case which I had showed, this patient had a plan for flow diverter above. He had a previous coiling, and probably there was a dissection at that point of time. You can see the loop into the this. So in these kind of cases, again, we'll use Neuron Max rather than the Cook-Rabe sheath. Again, you can see coaxially. So what you can see, this is the 6F DAC, that is the 4-4 DAC, extra long one, 6F, and then the Neuron Max. And then you can go through these loops and get straightened up. And once you reach there, then becomes a regular case. So just to summarize, a guiding catheter has to be high as possible. And this is ruptured small aneurysm. We like it in petrous cavernous ICA. 6F distal access catheters have become very useful nowadays. Any tortuous anatomy, we just use DAC and go high up. Obviously, we take them coaxially over a DAC 4-4. This is what we do. And now, this, of course, we are talking about going into the ICA once we are there. So we'll use a 6F distal access in difficult cases in straightforward anatomy and VOI. Coaxially over DAC 4-4. Again, I never push in guiding catheter over a wire. You can reuse them actually because all you are doing them is using them for a minute. Over a Terumo wire. If there are very bad loops and Terumo wire doesn't go, then we can use a 2-1 catheter. We frequently use Prola 21. Prime with NTG and nimodipine. And some of these cases, if a DAC 4-4 has gone up, but the guiding is not going in, then we replace Emplart's in the DAC 4-4. We don't take it out into the ICA. Just place it in the 4-4 catheter, and then the 6F catheter will go up. Coming back to this case, which I had shown with this funny looking 8 loop in the ICA, and they said this was the cerebral artery aneurysm which patient had, and this is what we have done. So there is a long sheath which is in place here, and this is the 4-4 distal access catheter high up there, and over that we are tracking the 6F. So now you can see this is the long sheath, and the 6F had gone through all these loops, and we are there. This is where we are, and after that, of course, one can go ahead with the balloon assisted coiling. Again, an artery like this with tight loops. So this is what we long sheath Cook, because the CCF was fine, and distal access 6F 105 centimeter, distal access 4-4 115 centimeter, and Terumo 3538. And again, what you can see this is the Terumo wire, this is the 4-4, this is the 6F, and you go all 3 loops. This patient has a very small ruptured aneurysm here, and you can see this is the 4-4, this is the 6F, and then the 6F has gone right there into the paraclinoidal region, and your aneurysm is right there. And so there is going to be no tension in the system, and then we could go ahead from here, we could go ahead with the coiling and finish the coiling from 1 centimeter away. Whenever there's a disease artery like this is a bad, maybe previous dissection or something, or FMD, you can see very bad artery, looking artery. It is better in one go to go beyond it rather than trying to work from below, not have any control, and all the time you are irritating. So at one time, use a distal access system, coaxial system, maybe cross it with a micro catheter, followed by a long 4-4 DAC or a 3-8 DAC, and then followed by a 6F, and then you cross this area. So then you know whatever you're done with this system, and then you control and get done with the coiling. Basilar top, very broad neck, and like this is a bad subclavian. There's a loop here at origin, then another loops, and this, and small aneurysm we're trying to do from below, it's hell. So again the same thing, this is a long sheath in, and this is the 6F, and then there is another, if you can make out, we go here, and in this case we have crossed it with a Prowler wire and a 3-8 DAC, and then we were able to take this loop, and go in there, and then it becomes simple job to take coiling. So we can, as I said, use a Terumo wire or a Prowler 21 or whichever micro catheter, and 3-8 DAC or 4-4 DAC. So usually 3-8 DAC we use when we have to take a 5F system, in some of the flow diverter cases, when 5F system is enough, that's what we do. Another thing you have to realize, some of these patients will have this FMD, you can see. So we have to be very careful in this artery, because this patient had a paraclinoidal aneurysm, which we had to coil. And you can see bad aneurysms and stenosis. So again, this kind of case will cross it with a loop of a micro catheter wire. Is easiest, it will never cause injury to this vessel, and once the micro catheter Prowler has gone in, one can take in your 3-8 or a 4-4 DAC followed by 6F. But as soon as we placed that 6F, there was lack of flow. We took it out, and we saw there was already spasm in spite of priming, and the artery was getting straightened, and it was getting kinked, and there was slow flow in the artery. A neat trick is just extend the neck of the patient. Some of these kinks, they just go away, and you extend the, this is what we did. We realized this artery was very irritable, whatever we gave antigen and nimodipine. So what we did was we just straightened the neck of the patient. That's the aneurysm we had to treat. And now you see the artery is straight. And it becomes very simple now. You cross it with the loop of the wire. So this is the Traxus, that's a Prowler 21, that's the 4-4 DAC, and that's the 6F. You get it right up there then, and then of course it becomes a simple job to treat this. This is a very nice case. We did it a couple of weeks back. It had dissecting aneurysm in like M3 segment. We had coiled it, it had ruptured, we had coiled it. In 6 weeks, it had grown a lot. So the plan was to do stent assisted coiling. Now how to go through all this artery was like this, loops around this. How to go through that? So we decided we needed a 5F system right there in the middle cerebral artery, because even the initial coiling wasn't easily through all these loops of the cortical vessels. So this is what we do. We have used a Prowler 21 over a Traxus wire. This is a 3-8 distal access catheter from the striker, and this is the 5F Navion. You take this all up. We have gone into one of the cortical vessels, which was not the vessel which had the dissecting aneurysm, and then Prowler has been taken up. This is the 3-8 DAC taking this cleidocranial tull. This is the 5F Navion. There was a long sheath below, and then 5F Navion has been taken right into the M1. Actually, it was going into the M2, and then it becomes something which can control in that small vessel. We could get in, and we were able to coil it and place a baby Leo in that very small vessel as well. So just to summarize, cannulations are critical for success. Different strategies, arch, IC, interclavian access, awareness of option, availability of hardware is very important. Long sheaths, what are the options? Distal access catheters, which is what you're going to use? Coaxial options, what are you going to use? And even you're going to use terumo wire, and when you have to use a micro catheter to cross the lesion, and sometimes when you have to replace it and using an extra stiff implants into this system, all these have changed the game, and one should be comfortable with the options and plan a strategy in a particular case. So let me come to the next part. We have gone there. Now sometimes we have to go beyond the aneurysm. Okay. So why do we want to go beyond the aneurysm? Because of course, to place a stent or to place a balloon in these cases. What are the key here? The wire talkability, the balloons, and stent anchor technique. So let me just go over that. So you have an anatomy like this. It may look simple, but it's not so easy to cross because the artery is pointing this way. So it will never happen that in this giant aneurysm you can cross it very easily. Usually you'll have to go through the aneurysm. Or you have a ruptured broad neck ACOM like this with the artery arising in an angle. How do you make sure your wire, you want to do a balloon assisted coiling and you can safely cross it easily into this ACA consistently? Because last thing you want to do is place a balloon in this vessel because you never really cover the neck completely. You have to go to the more difficult ACA division or MC division always. The more difficult the artery to go to, that's the artery to go to. And of course, we know that is where the neck is. Or an aneurysm like this, giant basilar. Again, you may think it's easy to cross, but you can see it is pointing here, and then the artery somewhere comes out there. So this is not going to be so easy about it. So how do we do it? Most of these giant proximal aneurysms, there is no point. If you are very lucky and your wire catheter process through, well and good, don't struggle too much. You have to then make a loop through, and most of them are unruptured, of course. When they are unruptured, you go through, form a loop, and then go through it. That's the way to go. And sometimes, so what we usually use is a balloon. Okay, usually we'll use a scepter balloon, then easy to exchange later on, or you can use anything else. Even eclipse balloon can work because with the traxus wire probably everything, but usually we use a scepter balloon for this. And cross it with a wire and then straighten. Sometimes even the balloon doesn't work, then we use a micro catheter. We cross it with a micro catheter, exchange with a balloon, and then go distally and then straighten the whole system. And this is what we had to do in this case. A balloon didn't go, and I think we had to use a micro catheter. So we formed a micro catheter loop and went through, then exchange with a balloon. You can see forming a loop through, then you inflate the balloon, straighten the whole system, exchange, and get your stent delivery catheter high up there, and then do the rest of the job. Again, coming back to this case, cavernous aneurysms, particularly a lot of these giant aneurysms are difficult to cross. So you have to again go through, form a loop, and then go through. Once, in this case, we are using a microcatheter to cross the whole thing, then exchange with the balloon, inflate the balloon, straighten the whole system. Yesterday, of course, Shabal showed a neat trick, and he just used a 2-1 catheter, and he placed the wire there. I've tried it once or twice, it didn't work out, but yesterday I could see what it did. Next case, I may try that out, okay? And inflate the balloon, straighten it up, and then you exchange. This case was planned as a surpass case, so we had to use a Plora 21, 3A DAC, and a 5F DAC, and the 5F DAC, we could cross it across. That was before the Cat 5 was available in our country, and we were able to place the 5F DAC distal to the aneurysm, and once it was distal to the aneurysm, of course, we have placed the surpass and deployed the surpass, one single long surpass through this aneurysm, and we almost got it right. Another technique which Shabal yesterday mentioned was, what can we use? You cross it with a 2-1 catheter, and then you don't have a balloon. What you can do, you can deploy our stent retrievers, and the stent retriever is in place. Then when pull out the catheter, stent retriever fix it up, and you straighten it up. Okay, so in a way, potentially you can even avoid exchange in those cases. So this is one of the cases given by my old students who have faculty in US now. So again, a large paracrinoidal aneurysm, very difficult to cross. You have to go through the aneurysm. So they went through the aneurysm like this, and if you can make out, then they deployed a stent retriever there, straightened the whole system, and then went with coiling and flow diverter placement. Now, crossing the aneurysm, but most of the situations which we encounter are ruptured small aneurysms, and you want to place balloon. As I said, in 80% of our cases, we take a balloon across. Once a balloon is across, your job is done. Aneurysm is going to go. You microcatheterize it, and then coiling is easy. So coming back to this case with an anterior-communicating artery with a pretty bad angle, broad neck aneurysm. So what we frequently use, everybody have their own tricks, but what we frequently use is what I want to synchro wire. And synchro wire will over curve like this. I will even give another curve here, make it like loops there. And most of our cases, I will say 95-98% of our cases, in these kind of cases, we can just cross it with a synchro with a perfect control over the system as well. It doesn't go into the aneurysm and crosses this. So this is what we have done, and after curving the wire like this, we can make it point, you can control it very well and slowly cross it like this. And once it reaches there, all you have to do with synchro, give it slight push and keep rotating it, and slowly it will take the turns and keep going ahead, and the wire we are able to usually send it up right into the ACA, and then you can take the balloon and coil this kind of aneurysm. The case which we just did last week, this patient came in, he had a small anterior choroidal and middle cerebral artery aneurysm. We didn't know which one was ruptured. Blood was all here, but this was the bigger one. Patient had already gone into severe spasm, know what to do. Again, this is a very broad neck one. You want to use a balloon, so we'll do intra-arterial dilatation. You can see the angle here. This is the MC in spasm, and this is the MC division already in spasm, ties in a very acute angle with a very, very broad neck aneurysm. This is the intra-arterial dilatation done. You can see the broad neck aneurysm now. So why you need it like this? And it's very difficult. So again, over curved synchro, you curve it like hell, make multiple loops of it, and then very much control. See, initially didn't go. This is the balloon catheter. So at times it helps to bring back the balloon catheter, and then the synchro can form that curve. Once it has formed this kind of curve, you just give it nudges and take your time, take few minutes, and slowly it will go. We went right up to here. But after that, you can see in the other plane, we can see where it is going in the vessel. It is all in the parent vessel, but it stopped there. It wouldn't move after that. It started bulging into the aneurysm. So another neat trick is why it is bulging, because this loop of the wire tends to bulge. So at this point of time, when the wire has gone in, you can track your balloon catheter right up to here, and that will give it support to go further. And this is what we did. It stopped there, so we have used the balloon catheter to go, we are not across the aneurysm, just across the neck a bit. Now it is given more stiffness, and more force transmission goes distally. You can see the balloon catheter tip here. This is the main balloon, this is the tip of the balloon catheter, the wire is here, and then we could take the wire further in, and then balloon could be placed, and we were able to coil this aneurysm. Yes, sometimes, but when they're unruptured bifurcation aneurysm, you can use the same trick which we showed, go through the aneurysm with a balloon catheter, inflate the balloon, straighten it up, and then do the coiling. Sometimes this I've used only, not I, one of my colleagues used it only one time I have seen. Again, usually we'll cross this with a synchro. This is a ruptured ACOM aneurysm, and my colleague wasn't able to cross it. So what he did was he placed a balloon in the opposite division, inflated the balloon, and that gave support for the synchro to go in, and then in this case, a stent-assisted coiling was performed. And as I mentioned, most of our cases nowadays, we are just able to cross with synchro wire, and we never exchange. But if you're not able to do, then sometimes you can curve a microcatheter, like this was a ruptured middle cerebral artery aneurysm. No, you don't want to place a balloon here and leave this unprotected. You will always end up leaving a lot of the aneurysm. You have to go into the most difficult branch. So in this case, we use a shaped microcatheter to go into that branch and then place the balloon right there and perform. These coils are not there. These are part of the neck which is overlapping the artery. You can do a decent job in this patient. So if I want to summarize the crossing the aneurysm in proximal large unruptured balloon loop technique or using a stent retriever, as Shabal showed, sometimes that just the wire talking can straighten these systems. Cross ruptured small aneurysm, we use a balloon scepter or a transform, and usually we just go over a synchro nowadays, is immensely useful. And thank you for all being here and listening through the thing. Thank you.
Thank you, Dr. Vipul. There are any questions or comments? Yes.
Yeah.
Wonderful presentation and a very important presentation for any interventionalist as such. I have a question and a comment. The question is, the 6 French that you took up distally, was it this ANVI DX or what was the catheter?
Usually, I will say whenever there's any tortuosity, then we take a distal access catheter. The one from the striker is cheaper. It is more difficult than Navian tracks very well. Navian from Medtronic is very good. No, sometimes when it's a straight anatomy, we are able to push up ANVI up to the petrous ICA. Petrous and even the lateral segment. I showed you the first case which I showed. That was an ANVI. Even ANVI we are able to take into the petrous IC and up to the lateral segment, but always over a distal access DAC 4-4.
What was that ANVI? It's a regular ANVI? Or
regular
ANVI had
no, regular ANVI.
Okay, I'm surprised it went that high up.
So you know what? You don't track it up. So when you use the petrous band, you have to rotate it. Of course, there's a 4-4 DAC up there, so it will not cause intimal injury. That's a key. You're not tracking it over a wire. And rotate it, and the rotation torquing movement takes a torque very well and turns and goes up. But as I said, most of these cases when you're able to go high up and there is any tortuosity, then we go for distal access catheters, not the ANVI. So maybe nowadays in 30% cases we use ANVI, but 60-70% of cases we'll end up using a distal access catheter.
Fantastic. And then the second part is the comment. I've practically given up on using the exchange wires now, like going through the arch. We have the select catheters. From neuron, you have the neuron select catheters, which are extremely useful, which is a coaxial system. Right from the groin, you go with the coaxial system, you put the select catheter, and over the select catheter, you'll be able to take your sheath up right away without an exchange.
I don't think they have, I'm not aware we have it there in Delhi.
We do. And
Yeah, we
then
don't.
this microvention also comes with this chaperon. Chaperon has two types. One is without the inner catheter.
Yeah, and one
the
with
other one with the
so,
with
but
the inner
most of
catheter.
the situation I'm talking about exchange wire is a very bad arch, and usual diagnostic catheters wouldn't go. Those exchange wire is only when you can only catheterize that parent vessel using a SIM.
Correct. I
And
mean,
usually
these-
that's the left common carotid when it's rising as a bovine arch and at an extreme angle. That's the time we end up using exchange with a SIM.
Got you. Yeah, in the past we used to use that. We used to use the VTK catheter and then
Again,
exchange
VTK
it.
is not available
Not
nowadays,
available in India,
you know,
but
yeah.
the chaperon and the neuron select, they come in SIM tip, so that can be used here.
All right, I mean, somehow they have failed to inform us, or this is not available there in Delhi.
Vipul,
Yeah.
the neuroselect catheters are very expensive.
I
They're
think that's-
expensive for UK too. So we don't use anymore. We use it, we have it on the shelf. With an 80 centimeter Neuromax or Infinity, you have a 100 centimeter diagnostic catheter in, you
Yes.
can push it in. So you don't need, Penumbra's catheters are very expensive. Okay, so we don't use it anymore. I put a small 8 French sheath in the groin, which means you have control on the groin, so you don't have to get into trouble. Neuromax goes through an 8 French short sheath, and in the Neuromax I keep 100 centimeter catheter. Most of the time, you will get through it. And you don't have to use penumbra catheters because they are too expensive.
In fact, as I mentioned, until it is a bad arch, we use Cook sheath because it's very cheap. It's like 7,000 rupees. Even Neuron Max is like 25, 30. So in a straightforward cases, we use that's the cheapest sheath. And there's a bad arch, then we switch to Neuron Max, again because of the cost issues.
Even Destination has been always good and cheaper than Neuromax.
Yeah.
The problem with penumbra products is, now I don't know whether you guys have it, but the penumbra in stroke, they have made the packet. So you have to use the whole thing. So you need the A68 and their own tubings and the whole thing. Many of us have stopped using it because it's too expensive. So, you know, if penumbra is not going to change, if the industry is constantly going to try and take money off from, at the moment, all of us have the same problem. So we don't use much ACE anymore because they have changed the packaging, and that probably will come to India too. And many of us have stopped. We use A68, and now because it's together, I think it's pretty expensive.
Cost is a major issue. Why would I push up the ANVI? It's to save cost. I mean, these are
Cost.
patients who are not affording, then you don't want to use a distal access catheter.
Cost is an issue in Western world also.
Here
Today
it's
we cannot just take a catheter and use it.
Yes.
We have to look at the cost. You know, you can't put devices in without a cost. So I think you're right.
I understand that. I mean, cost is certainly an issue. I'm surprised that you're bringing this up. And but in stroke, when you're doing an acute stroke with a difficult arch, it makes a difference in terms of your time. Like for you to take a catheter, do a diagnostic, then exchange it,
I think
you're
our,
losing time.
No,
And
you-
practically, it
chairperson
saves a
or
lot of
organizer
let's
are getting a bit
let's discuss
fidgety.
it further.
Yeah.
So maybe this is last talk of the session. Invite Dr. Raj, or you will be presenting this case, carotid puncture and difficult vertebral artery access.
So I'll just be going over the steps of carotid puncture. Can I have a slide? Okay. So this is a patient who presented with subarachnoid hemorrhage, and he had an interrupted aortic arch. So there's a broad-based echo aneurysm that you notice there, and if you see there's an interrupted arch. So in this patient, we decided to go ahead with a carotid puncture to access the aneurysm. So the hardware we use are a 4 French micropuncture set, which usually comes in with a 21 gauge needle, a 0.18-inch wire, and a 4 French dilator. It is preferable to have a 0.25 Terumo 5 French dilator, O35 Terumo, and a 6 French sheath. So what is the positioning? It is preferable to turn the head to the contralateral side by 10 to 15 degree, and it's also preferable to extend the neck by placing a sheet under the shoulders. We generally use ultrasound guidance in order to avoid the internal jugular vein and to delineate the bifurcation and to avoid any atheromatous areas. In this patient, obviously we couldn't have a femoral puncture to have roadmap of the CCA. So if you have a femoral axis, then it is preferable to have a roadmap of the CCA as well. So the first step is to localize. It's preferable to puncture approximately 4 centimeters above the clavicle and 2 centimeters proximal to the bifurcation. And the first step is to puncture under ultrasound guidance with a 21 gauge needle. As soon as you puncture, when you have the reflux of blood, you can take a contrast injection to delineate the bifurcation in the external carotid artery. And then you direct a 0.18 inch wire into the external carotid artery. Once that is done, you take the 4 French dilator over the 0.18 inch wire. And then, in case you have difficulties to exchange to a 5 French dilator, you can use a 0.25 Terumo wire. So now you have taken the 5 French dilator into the external carotid artery. Now it is compatible with the 0.35 Terumo wire. And then that can be exchanged with the 6 French sheath. So I'm going to go over the case here. So this is an injection of the right common carotid artery with a 21 gauge needle. Now we have been able to identify the bifurcation, and now we know the external carotid artery. So then we take a 0.18 inch wire into the external carotid artery, and then over that we have taken a 4 French dilator. Once the 4 French dilator is there, you have exchanged with a 5 French dilator, and then taken an 0.35 Terumo wire into the external carotid artery, and then you can exchange with the 6 French sheath. So these are the steps, and once the sheath is in, then you take the guiding catheter into the internal carotid artery. Once that is done, you fix the sheath to the skin, and you can see the ANVI there. And then we have access to the aneurysm. So what are the issues in general we notice here? One is you can have spasm and thrombus formation and dissection. So the steps to avoid this are preferable to use ultrasound guidance and roadmap guidance if you have one, and to have a good reflux of blood and take the 0.18 inch wire without any resistance. So the other issues that you can face with are delayed hematoma and pseudoaneurysm formation. Again, use an ultrasound guidance. Preferable to use a single wall puncture under ultrasound guidance. At the end of the puncture, you can do ultrasound guided compression, manual compression. And the closure devices that have been used are, one, they have used AngioSeal. There is a series of 40 patients where they have used AngioSeal and they have not had any complication, thromboembolic complication. And there's another series wherein they have used Star Close. This is a device that sort of clips the artery from outside, and there is no material within the inner wall of the artery. So we do drop the blood pressure that you can do pharmacological drop in blood pressure to allow for hemostasis. We generally do a follow-up ultrasound after 6 hours and after 24 hours. And the most important thing is to have a close watch on the airway. We have also done, there's a paper on looking at the safety of surgical cut down versus percutaneous puncture. So surgical cut down is also equally safe. You can open up, this is not possible in acute situations like where you're doing stroke, but in other cases you can have a cut down because this is also equally safe. So specific precautions which I would like to go over is use a atraumatic 0.18 inch wire. Never take the dilator into the internal carotid artery. This is an important step to avoid dissection, spasms, and so on. So you take the 4 French dilator followed by a 5 French dilator all into the external carotid artery. And again, when you're taking the 6 French sheath, along with the dilator, you preferably go into the ECA, remove the dilator, and then direct the wire into the internal carotid artery and take the system across. Whenever you have good ACOM cross flow, then it is all, you can do carotid compression, and there is always good perfusion into that particular territory. You can drop the blood pressure a bit. So this is a patient who had an interrupted aortic arch, and there is more precautions you need to take when you're lowering blood pressures in these patients, especially when they develop vasospasm and all, because you need a higher perfusion pressure in order to maintain lower limb and spinal cord pressures. Thank you.
Thank you, Dr. Raj.
Yeah, Raj, one comment.
Yeah.
So there was another case I had done like 12 years back, and that was for intracranial atherosclerotic stenting. We had to do a direct puncture. So what I did in the end was, I was afraid to do a manual compression on double antiplatelets. So I told our cardiac surgeon, vascular surgeon, so what they did was on the table they came in, they give a small nick and place a stitch at the puncture site. So that's another way to close it down if you don't want to use a closure device and you don't want to risk a manual compression. And I thought that was pretty neat and takes all the stress away.
So in the past time, we didn't have this access and wherever, and we were keeping using direct puncture frequently. And so, in Rothschild, we started the Cameo study with the stents, and so with onyx inside the aneurysm and so whatever. And one day we had such kind of case, so we couldn't access by the femoral. We punctured the carotid artery, we placed a cardiac stent in the brain of the patient and whatever. And at the end, we said, oh, now we have to compress. And the carotid artery has a stent, and we don't want to thrombose the stent. So we put an angioseal here, and so Raphael Blanc published it. It's in the case is in the AGNR. We put an angioseal in the carotid artery, and we followed the patient with MRIs and echodoppler. And we'd never seen any complication afterward. And people were keeping sending us mails and saying, so how could we use it and whatever. So it was only one case. But now with the star close, for example, the star close, to my opinion, and so intellectually speaking, it's much more adapted than the angioseal to put in the carotid artery, because it's just a node that you make here on the carotid artery. But if you put the angioseal, you have the anchor inside the artery, and I'm always afraid that something from this will migrate distally.
So there is a series of 40 cases with angioseal, and they have not encountered any problems. And there were 2 cases with star close. One of them, the clip was okay. The other one, it didn't apply properly, and the patient developed a massive hematoma in the neck.
Yeah, it could be, yeah.
That, if it doesn't apply properly, then it's an issue with the star close, I think.
I agree.
Yeah, thank you.
Thank you, Dr. Vajpayee. Going forward, may I request Dr. Srinivasan, Dr. Sunanda Anand, and Dr. Vivek Singh to chair the session, please. Our next session is We Have a Problem, Technical Innovation. Vivek Singh.
We start the second session with Vopal again. Thromboembolism, prevent, anticipate, and manage the drug program.
So, actually, today's both talks were supposed to be taken by Matthew and Dr. Santosh Joseph. The access and thromboembolism, somehow they were not able to make it. And I had to rope myself in. All right. Matthew has beautiful images of access and everything, and I thought, but they were not, for some personal reasons, they had to cancel. So, coming to thromboembolism again, so I will go quickly, I think we are already running late. So, in aneurysm coiling, most of the complications are thromboembolic, not rupture of the aneurysm in the current era. I think rupture of the aneurysms, and we do small rupture, is 1% or less nowadays. It shouldn't happen by and large with the modern coils and digital access systems. Everything has become so much more better, but thromboembolism is much more common. There was a big series, 681 patients. 4.7% had complication rates. Another patient series, 24% I think is too high. DWI-MRI was 40% positive in ruptured aneurysms, and 30% in unruptured. And again, another series or 200 patients, 2.7% had thromboembolic complex. They're all varying. So I'll just go quickly over some case studies that how we prevent them from happening. Once it's happening, how do we analyze and treat them, and on follow-up, what do we do with these patients? I think I will skip that previous slide, so come here. So what is the usual protocol? Let's come to it. So usually in all a ruptured, we give 3,000 units of heparin after puncture. Yesterday, Tufal mentioned 5,000, and Tufal, I used to give 5,000. And then the youngsters with me, they said, okay, 5,000, no sir, we should start with lower down. I think 5,000, in my initial 10 years, I used to give 5,000. I mean, in anesthesia, when you give patient heparin, it doesn't really matter much. And I think my thromboembolism was less, not more, and no ruptures even then. But nowadays, we usually tend to give 3,000. And as soon as the first coil is given, we just raise the ACT to give another 1,000 or 2,000 units, and then we raise the ACT to more than 2 times 250. So in aneurysm coiling, you start with a low ACT and you keep going high up. I think this pointer is going to go, so tell them to, okay. And later stage of the coiling, when we know aneurysm is secure, we raise the ACT to more than 300. So we always have a baseline ACT, and then we monitor accordingly. I think. And we watch carefully for any clot. Again, our experiences, and I've been to Western centers, I think we see more thromboembolism maybe in Indian population, more thrombus formation. My colleagues who are trained outside in Canada and US, and they come by, they say no clot will form, but we see clot forming for no reason, short procedure, coils right in the aneurysm. So we are very vigilant, and we watch for any clot, and basically what will be seen as slight haziness in a procedure in the adjacent artery, and even after the procedure, we at least watch for 20 minutes. Most of my thrombus formation is after coiling has been completed, you have done your runs, and then after 10 minutes you take a run, you see a small clot forming. At that stage, we handle it, it goes pretty well. If broad neck, I'm sorry for this pairing, if broad neck and well coiled, usually a small neck, we may not give any heparin post-op, then we give Clexane for 1 or 2 days, if it is a very broad neck aneurysm, and followed by a low dose aspirin, depending upon the ventricles as well. Of course, if ventricles are dilated, then you don't give these drugs, you just wait and watch. I'm talking about basically small ruptured aneurysms. In unruptured, we give antiplatelet, we give double antiplatelets to all our patients, by and large, until it is a very, very simple case, and then do it. Double antiplatelet a day before, ecosprin and clopidogrel, or sometimes even passagular ticagrelor, and if uneventful, we can continue with single drug for 3 to 6 weeks. Of course, I'm talking about when we don't have and place a stent, it's just a regular coiling or a balloon assisted coiling unruptured. Now coming to case situation, when just the coil mass, or we don't find any reason, is basically because there's a foreign body, and when you're placing, you're causing some flow change, and that leads to thrombus formation. This is one of the very old cases when I was in All India Institute. So this must be like 15 years back, and you can see vertebral base of fenestration with an aneurysm. We were doing coiling, and you can see coils are within the outside the parent vessel, but you can see some haziness coming in. That's a clot formation. At that stage, you continue with the coiling. You don't want to give RioPro before securing the aneurysm. We just raise the ACT, and then in the end, it all cleared off just by heparin. So, but you have to watch for something like this very carefully. And until you are watching for it, you won't see it. As I mentioned, delayed thrombus formation, subarachnoid hemorrhage, this is the IC aneurysm here, balloon assisted coiling done, short procedure went pretty well. Immediately one will be very happy, this is a small neck aneurysm, how does it matter, not a very long procedure. And what happens is we do our angio-CT and AP lateral views, and then you see suddenly this is looking worse, there's some clot formation here. And then we start giving 8 minutes, you can see it's much more. So this is like 10-15 minutes after the completion of the procedure, okay? Then you start giving RioPro, over RioPro it increased, you can see a lot of clot, and then this is like 15 minutes after the procedure when it really cleared off, and we know now we are in a safe hand. So this is what I'm talking about. You have to do delayed runs, most of the clot form, and at that stage giving RioPro or any other agent which you prefer will handle the problem, and you will not have, sort of unpleasant surprise in the post-operative period. What is the thrombus protocol? If, as I showed you, minimal insecure aneurysm, we increase the heparinization. If there is significant clot and secure aneurysm, injectable antiplatelet agents. Usually we use F60 okay, RioPro, 10 milligram through the microcatheters. We'll give like first 4-5 milligrams fast, and then slowly the rest of it over 10 minutes. Some people do even give a complete dose as IV, and some people give 5 milligram IV and 5 milligram intraarterial. I don't know whether it makes any difference. Post-op, if the aneurysm is very secure and there's a significant residual clot, then infusion, but most of the cases you don't need to do this, it clears off then and there. Otherwise, we'll tend to give some heparin and oral antiplatelet agents in these patients. These are the three agents which are epiximab, epitofubaride, and tirofiban, which are used. You can use whichever agents, but there is some difference between them. Epiximab is longer action but reversible. It can be reversed using agents, right? And tirofiban, which is commonly used, short acting, but it is not reversible immediately. So we usually tend to use epiximab in our cases. Now coming to the other cause, which is unusual nowadays, maybe it used to happen more in the past guiding systems, is because of the guiding catheter or parent vessel issue. So usually it can be a flush issue, or you have caused spasm, slow flow, or you have pushed through systems called the dissections, or you have tried to use old material, which one should not be using. This is again a very old case, Ames case. Case was being done by one of my colleagues, and massive thromboembolism. This is a DACA aneurysm with severe spasm. It looks MCA is gone here. All we could do, because aneurysm was secure, we raised the heparin a lot. Artery recanalizes a fresh clot formation. We went ahead with the coiling, and after the coiling, we gave Riopro and completely recanalized the arteries for some cortical vessels, and patient did pretty well. So you have to see then what to do. If aneurysm not secure, increase the heparin, secure the aneurysm, and then give Riopro. This was a 40-year-old man with SH, blister aneurysm, ICL looks good, and as soon as 3D was done, patient collapsed. You can see the ICS closed off. This is a classical, it is dissected probably. Patient was right on the table, they immediately intubated. There was no collateral, there was no ACOM or PCOM, so we knew we were in trouble. So we immediately closed with a microcatheter, took an injection, you are in true lumen, placed 2 overlapping carotid stents and completely recanalized the artery, and then we placed 2 overlapping enterprises in the blister as well. And thankfully patient did very well. So once you recognize, form a loop of the wire and cross the dissection and quickly place a stent, there is no other choice, and load it with antiplatelet agents, and then we watch. If there's any clot formation, you have to give Riopro in this patient. Now you have to really, this patient had broad neck middle cerebral artery aneurysm, and you can see the artery here, dilatation irregular. So this is clearly FMD. Now whenever there's FMD, you have to be very, very careful. You can easily dissect vessels. Sadly, in retrospect, you can see this artery also looks irregular around here. We thought we'll cross this area, place in the Petrus ICA. This was old time before the DACs were available. This was done a long time back. I think we tried to take ANVI distally across the FMD, but what we caused easily, without any trouble, we were, we caused a dissection around here. You can see we gave her heparin, we performed the coiling of the aneurysm. We thought we'll just leave it there, and this is what happens on follow-up. The ICA is closed off. There are some ECA collateral, great ACOM, some PCOM, and the ICA went away. So we realize some of these dissections may not be so benign. So when there's a small dissection, we just give heparin. If there's significant flap, you may think about a stent placement. We learned this the hard way. Another patient, bad looking ICA aneurysm. Plan was, this was a rupture. Initially stage, we just did balloon assisted coiling. And then when we could come out, you could see there was some trouble in going through this loop. There is a small dissection here. Now you can see it much better from a previous experience. And this patient, we had given double antiplatelets to this patient. So we just had, and in this kink, we placed an enterprise stent here. And this is the follow-up. It looked pretty well. So some of these flaps, we were afraid that it may just progress. This is also probably a dissecting aneurysm. Clearly, the patient has a tendency to it. And so we placed one stent here as well. So this is about guiding. So small dissection we just manage by heparin. When there are large dissections, you have to watch very carefully and think it over whether you want to place a stent in the emergency or not. Now coming to coil prolapse. Now coil prolapse can happen after detachment because other coil may push it out, coil may get stretched, unwanted detachment, microcatheter withdrawal may lead to some coil prolapse and later on with the flow as well. This patient, we have planned, IC aneurysm, balloon assisted coiling by done, and as soon as we detached it, you can see a tip of the coil came out. Usually this much is not a problem. We just increase the heparin in these patients and later on you can give antiplatelet. It's not a big problem for a tip of the coil to come out. Heparin followed by aspirin. Broad neck PCOM, this was one of the first few cases done in the country using 3D images a long time back, 17-18 years back. So fetal PCA, coiling done. During microcatheter withdrawal, a tip came out. That can happen. So nowadays with microcatheter, when we are withdrawing it, we use a wire to clear the tip of the microcatheter and withdraw it very, very slowly. If there's a balloon, we inflate the balloon and then withdraw the microcatheter. It came out, clot formed, Riopro govern, and you have to clear it up. Broad neck ACOM, before we were using balloons, coil place, looked well in place, and we detach it and a tip comes out. We increased the heparin, completed the coiling, but patient at post-op had in evening had weakness. We could see, I don't know whether we can see some small embolism there. Angiogram done in the evening shows a clot formation beyond where the coil tip had come out. So we gave some ReoPro, cleared it up, and kept the patient on aspirin layer after a very small infarction. So delayed thrombus, usually we watch it for half an hour, it doesn't happen. Really, it can happen. So to watch the patient very carefully, we gave ReoPro, heparin, and aspirin. This is a very unusual case. We had only this once, ACOM aneurysm. We placed a balloon, did coiling. This patient was due for some surgery. We didn't want to place a stent. We thought this is reasonable. Post-op, patient didn't wake up well. We did an angiogram. The whole coil mass had rotated and come out. So really something like that happened. And then we gave ReoPro. The artery came back. We kept debating what to do with the coil. We left it there. This was an unruptured one. The artery came back completely. Patient woke up very well. But this kind. So why this happened? I think because we underpacked the aneurysm. This was done long time back. I think we underpacked it. We should have packed it very well, make it a harder mass, and then I don't think it would have come out. Coming to stents, antiplatelet resistance can be there or incomplete expansion. These are the two main reasons why you may have clot formation. Broad neck paraclinoidal, we use an enterprise, did the coiling. 4th day post-operatively, patient was due for discharge. For some reason, they stayed 2 extra days in hospital, and she became hemiplegic, aphasic. We did an angiogram, and you can see clot all over in the stent. You can see clot around here, here floating. We gave 10 milligram ReoPro and it almost completely cleared up. We realized there was antiplatelet Plavix resistance. 25 to 30% may have resistance, and most of us don't have verified now. So we added, this was before the era of ticagrelor and prasugrel. So nowadays, for our less than 75-year-old, we have an aneurysm, whether stent is used, flow diverter, we have stopped using clopidogrel. We only use prasugrel or ticagrelor along with aspirin, and then we see less of these problems. This was again in the Plavix era, aneurysm, ruptured aneurysm, which had been coiled for the neck, pipeline was placed, and this is what I mean. So when we are watching it, suddenly you see some haziness coming in here, and that's the step when you should suspect there's a clot formation. And earlier the ReoPro you give, the better the response is. So we gave ReoPro, and sadly this patient had one of the, and we make the Plavix BD at that point of time. Sadly, she even had ReoPro-induced thrombocytopenia. She had severe thrombocytopenia. So after giving ReoPro, we were infusing with platelets for next few days. So these kind of complications can happen, and one has to monitor accordingly. Another patient, giant aneurysm, cross through the aneurysm, straightened, we are placing pipeline, and you can see the pipeline didn't open up completely here. So whenever they're not completely open up, it creates turbulence, it will create thrombus formation, and if you can see, there is some clot formation all around. So whether this was because of the incomplete opening or whether there is resistance, so again the same thing. What we did was, first of all, we took a balloon and inflated the balloon, that didn't work, then we pushed the balloon and then it opened the stent here. We gave ReoPro, cleared the artery, and then make the Plavix BD in that area, again before the ticagrelor and prasugrel were available, and then the patient did pretty well. I think we can skip this one. Now, so stent FD, what is our protocol? In unruptured, we give aspirin, and usually we use prasugrel more commonly than ticagrelor a day before. Nowadays, I mean, whether it's right or wrong, I don't give it for 5 days. A day before, you just load them, it works pretty well. It doesn't matter. Aspirin, 150 milligram later on, first 300, then 150 milligram, but remember, it has to be 75 milligram with ticagrelor. That is a key thing. Otherwise, there is resistance. Higher dose of aspirin with ticagrelor, they have resistance. So you have to use 75 milligram of aspirin, and prasugrel 10 milligram per day, ticagrelor 90 milligram BD per day. Usually, we tend to give double for 1 year. I know, I mean, a lot of my Western colleagues give for 3 months, 6 months. Again, probably our artery more thrombogenic. Now I'm thinking of switching back to 6 months and see what happens. We tend to give for 1 year, and then only aspirin, low dose aspirin. Just a last slide, sometimes some patients just have coagulopathy, they are hyperthrombotic. This is a long time back, again in AIMS when we were there, this before I think even the 3D era, this patient like a moya-like pattern, both ICs occluded, posterior circulation, multiple aneurysm. So he had this broad neck basilar, I think there was an ICA aneurysm and there was a pica aneurysm. As soon as placed one coil, the whole thing thrombosed, and you can see the clot started forming in the basilar artery just with one coil. So we had to give more heparin, I gave some heparin and all, and it tended to settle. Then we placed one coil in pica, and then pica also started to go, and again we had to give more drugs. So later on, we found a drop in the platelets. This patient had heparin-induced thrombocytopenia. This is an unusual condition, multiple exposure of heparin, then this reaction can happen. It leads to thrombocytopenia, but most of the complications are thrombotic complications. So sometimes when you see a very unusual kind of clot formation, useful to get immediate blood investigation done whether there's a drop in the platelets as well. And the control is that no more heparin has to be the biggest, the worst thing you want to give more heparin to this patient will cause more of this reaction. We published this case in AGNR as well. So just to summarize, management can be heparin, Riopro, blood pressure and volume. TPA, you never give in ruptured aneurysm, it leads to bleeding. Never ever TPA. So you have to analyze how you escalate, you have to analyze how much is the clot, what is the cause of the clot, what is the diameter flow, small artery clot, you have to give rapidly switch to Riopro. ICA, small clot, you can wait and watch. Aneurysm is secure or not, aneurysm not secure, it has to happen. Aneurysm is secure, you can go to Riopro, and whether there is any potential collateral supply there or not. So I just want to summarize by saying major cause of complication and coil, catheters, prolapse, stents, coagulopathy, they can all cause. We have to have a protocol for heparin, antiplatelet drugs and injectable agents, careful watch during and most important after, and proper visualization, early visualization of clot is the key in these cases. Thank you.
Another wonderful another good presentation, Dr. Vipul. And as you rightly said, I think the key point is after you coil an aneurysm, clot can form. So please keep looking for it. I
Yes.
love that. And with regards to your changed protocol of not using Plavix, I think there was publications and which says that the South Asian population has about 24% resistance to Plavix compared to the rest of the population. I think it is better to follow the cardiologist and switch over to prasugrel or ticagrelol, which is much more effective. Any other comments?
I just want to ask the house, how many of us are using ticagrelol regularly for our FDs and stents?
Yeah,
2,
sure.
3, 4, 5. Because once we have switched over from Plavix to ticagrelol, we hardly see thrombus.
Yes.
Like it's very, very effective. We hardly have used Riopro in the last 6 to 8 months. I think.
Yeah, usually nowadays in stent-assisted coiling, unless your stent is properly deployed and you use these agents, then we don't see thromboembolism. That's true. Yeah, Shabel.
So I'm not speaking about the ticagrelor, but so regarding the case that you showed regarding the apposition of the flow diverter over the wall of the artery.
Yeah.
So you are perfectly right that it's a source of thrombosis. So I wonder if in the future we can a comparative study, right? So between deployment of the stent, of the flow diverter, and deployment of the stent followed by an angioplasty inside the stent with a balloon. So 2 arms in order to see what's the effect on the ANVI treatment and the effect on the thromboembolic events. I'm sure that we will get some difference in both cases because in most of the cases we have this small gap that you showed. So which is source of thromboembolic events, and so we don't take care of it a lot, and after what we are surprised to get clots and occlusion of the stent.
Shabel, you're absolutely right. That's the key. But I will make 2 points regarding this. Number one, I think the most important is how we initially deliver the flow diverter. Of course, in situations, balloon is a great thing, we open them up. But I think the way we initially take time to deliver and get a good wall opposition, I think that is most important. Secondly, having this possibility, and there are a lot of youngsters here, having this possibility of later on doing balloon angioplasty of a flow diverter should not be in your mind. They should focus on initially getting it right. I just don't want people to think they can deliver and do angioplasty and everything will be fine. Because flow diverter opens by shortening, So at times it may happen even during the angioplasty, angioplasty doesn't shorten the flow diverter. As I showed yesterday in the blister, we try to shorten them. So you have to really shorten the flow diverter when you're delivering. If the flow diverter you have delivered under force and shortened there, even when you do angioplasty, it will open up. If it is stretched out in that area, it may still not open up. So I think the key thing is both. Initial delivery is the key. You get a good wall opposition, take all your time. Having good imaging is very important. And in situations, or maybe as you say, always having the option of angioplasty. Yeah. I think, we're running quite late.
Thank you, Dr. Whipple. Now we invite Dr. Moinar for the next session.
So, again, good morning, everybody. So, prolapse of coils during the procedure, how to make it, how to solve the problem. So, I will make it by two cases. The first case is this male, 79 years old, SAH. So, you can see the bleeding here. He has this ACOM aneurysm. And so it was done 2 weeks ago. So one of my colleagues was in his honeymoon, and the second one was in a congress, and I was alone in the department. And as you know, when we are chief of a department, we have a lot of administrative skills. And when this guy arrived, so they were the fellows with me, and so we saw the case, and they told me it's easy for us. Let us make it and go to your meeting. So I went to the meeting, and they coiled regularly. So they didn't take any balloon any balloon, and so they used this this material. So we usually use the left groin for monitoring, and so this is their procedure. So they started by the angiogram here, the working projection here. They entered the sac, coiled it. So you can see the movement of the image. This is the Siemens machine which usually focus, and so we are accelerating here. So this is why you are seeing the image moving. And so till now everything is going okay. And so you see here, so they arrived to the level of the neck and they kept coiling. And so I think that this is the last one, yes, here. So they tried to put one here and they didn't succeed, and the microcatheter was coming back to the neck. Yes, so they tried to pull back the coil, they pulled it back, but the loop which came outside is from the previous one. And we had a loop like this. They tried to go again and to catch it with another coil, but they didn't succeed. So here, they called me, and they told me we have a loop here. Should we put a stent? And they were afraid because we were in the acute phase, and perhaps the patient needs a shunt. So because he was Glasgow 14 at the arrival, and so probably he needs a shunt, and so we don't want to put a dual antiplatelet. So I told him no. I told them no. I'm arriving in the department. So we came, and so we decided to make this. So slowly and gently to take a balloon. So we bring out the microcatheter. We exchange with the Transit 14, so with the docking, and we bring a Scepter XC balloon and we place it. And by gently inflating and deflating the balloon, so you can see that we make a massage of the loop here. Do you see how we inflate and we deflate the balloon? And so this is the control at the end of the procedure. Oh, excuse me. Oh, it's usually the case here. Okay, so this is the control after the procedure. You have a little loop here, which is totally different of what we had here. And so we change, so the vessel now is open, and here we can keep the patient with only aspirin. So unfortunately, on the previous one, I tried to show you the difference between both. If we take it here, perhaps we can get it. So here, after the massage, So here is the inflation and the deflation of the balloon again. Okay, the control. Okay, control here. And here is the difference between both. You can see here the loop. So I cannot keep it inside the vessel here. Here the loop is totally different and the vessel is patent. Here we can keep the patient under only aspirin, and so we don't need a dual antiplatelet for it. So just keep in mind that the balloon could solve the problem. And here, so because they were alone, I let them go with the simple technique. For me, the balloon, when we have to put coils inside the sac, so in 90% of the cases we put a balloon, because the balloon is safe for coiling, for thromboembolic events, and for rupture of the aneurysm. In case of rupture, you inflate the balloon and you finish it. Speaking about rupture, okay, so speaking about rupture, this is case 2. So this is a patient, 53 years old, SAH. So you can see that it's a right Sylvian fissure bleeding, and he had 2 aneurysms, one MCA and one PCA. The operator treated both of them in the same procedure because he was not sure which one bled at this time. And so with the follow-up, we saw that the PCA aneurysm bled, regrowth. So we decided to treat this aneurysm by putting coils and stent down. So this is the situation here, recanalization. So, of course, we don't jail in the department anymore if we are not making a Y stenting, and you will see why. So here, the decision is to make a remodeling technique, coil the sac, and afterward put a stent. The patient was prepared under dual antiplatelet. I'm showing you this image just to tell you that the right P1 was perfectly open. So we can condemn the PCA, we can occlude the PCA. So here you can see that it's a regular technique. We are navigating the balloon, placing the balloon, and afterward putting the microcatheter inside the sac. And so I should stop it when it's, you can see the micro inside the sac here, inflating the balloon. So this is a scepter C, because we want it to be inflated like a sausage and not a pear. So we don't need any budge, so we take the scepter C. And here we were injecting, and so you can see here that the patient is moving. Why he is moving? Because the aneurysm bled, right? So if the patient moves like this during the procedure, he's under general anesthesia, so it means that there is something which is happening. At the beginning, on the PCAM, sometimes you have an irritation of the third nerve here. It could move the head of the patient, but usually when it's the case, it means that the patient bled. Whatever, he bled, we have the balloon, we inflate the balloon, we coil, and that's it. So this is what we did. So we went here. You can see the bleeding downside. And so, okay, we inflated the balloon, and we kept coiling. You can see the procedure here. We inflated again the balloon. So you have the stagnation of the contrast medium inside the artery, and we kept injecting the coils. And here we were injecting and injecting. You can see that there is a free space, which is the subarachnoid space and whatever. We don't worry about it, and so we keep coiling, and so you can see that the balloon, the border of the balloon is okay for the coils which are put. And so here you don't know where you are injecting the coils. In the subarachnoid space, what you want is to totally occlude the sac. And so here we deflated the balloon. We made the angio control. You can see that the PCAM is totally patent, the P1 is totally patent. We made the CT scan, and you can see that this is the CT scan. We had only subarachnoid hemorrhage and whatever. So we inflated again the balloon. And so with the deflation of the balloon, here we finished with the coiling. With the deflation of the balloon, you can see something which is moving. And this is the whole coil which was coming inside the artery. So what should I do here? So if I inflate the balloon, the coil go inside a space. When I deflate it, it will come inside the artery. So here again, I inflate my balloon. The coil goes inside the space, and I deflate it, and it goes inside the artery. Here I have only one solution, is to put a stent on. But how to put the stent on? Because when I deflate the balloon, the coil migrates. So just I have to make it by catching the coil in case of it will migrate. It means that here I have a scepter C. A scepter C is a dual lumen balloon. So I can navigate my stent inside. So the Elvis Junior, for example. But I have to start deploying the stent prior to the deflation of the balloon. But yes, you will tell me, if you start deploying the stent, you are obliged at one time to deflate the balloon, otherwise it will not come back, and so you will get in trouble, right? So between inflation, total inflation, and total deflation, there is some intermediate solution, which is a partial deflation. And so this partial deflation will be progressive with the deployment of the stent. So you will see how we do it. So we start by bringing, so this is the deflation. You can see the coil coming inside the artery when we deflate. Do you see? So now, look at this, okay? So we inflate the balloon again. And so, no, here we are over the deployment of the stent. So you didn't see it very well, perhaps. And so this is the last control. No, I would like to show you, yeah, here. You can see the deployment of the stent here. And so you can see, it means that you keep your balloon inflated. You start deploying the stent. So once the flare of the stent are outside, you deflate very gently the balloon, and you continue pushing the stent. So if you are trained to deploy a stent, a regular stent, you know that sometimes by pushing the stent, the micro will come back. So you deflate very partially the balloon, and so you push the stent, and you keep the balloon coming back, and like this you will catch all the mass. And so this is the control that we've got after the procedure. So you have your coils here. So this is not the working projection. This is the lateral view. And so this is the AP and lateral view. And so you can see on the lateral view, all the mass is catched and the stent is inside. So we have two different situations. The first situation was during the acute phase of a ruptured aneurysm where we didn't have to put a stent, and the second situation where we can put a stent, but they are totally different, both of them. At the beginning, the first one, it was a loop which was going outside the aneurysm, and the second one, it was a whole mass of coil coming outside. Thank you.
Shabul, what did you do with the antiplatelets?
So here the patient, the second one you are speaking about.
Yeah, the second case.
So the second case, he was prepared already by antiplatelet for the stent deployment after the remodeling. So this is what I said. So we make the remodeling all the time. We don't make jailing despite in Y stenting when I'm planning for a Y stenting. So all the time we make remodeling and throw the balloon, we put the stent afterward. So this is our technique. So because I believe that with the remodeling, in case of problem, you have the balloon. Second, with the remodeling, you can pack better your aneurysm. And third, so you have the double lumen balloons, and so you can deploy the stent inside. So I finish my procedure, I make a CT scan. I see what happened during the procedure, and after what I deploy my stent. But this patient was planned for a remodeling followed by stenting. So it means that he was under dual antiplatelet. So the protocol over a while we were under Plavix and aspirin. Here we continue by Now we take the Brilic and the aspirin. So I keep Brilic for 3 months and aspirin for 1 year, and only 1 year.
So I guess you are using Scepter because that's where you're going to push your LV Junior through that.
Yeah, exactly.
Okay.
Exactly.
So you could probably use Aclino also because Aclino
Yeah, of course.
Aclino goes through that as well.
Yeah. So in these dual lumen balloon, we can use the low profile stents like the Leo and the Elvis Junior. Yes, the Leo baby and the Elvis Junior. Okay.
Good, wonderful presentation. With regards to your first case, this massaging was a very good technique, and I've had this experience just trying to put a wire across, then with a little tickle of the coil, it retracts back. I've seen that happen. And with the controlled massaging, how did you practically do it? What kind of a syringe do you use?
Yeah. So usually here, so for example, we use the Scepter XC, and so of course the massage we have to do it always on the roadmap in order to see exactly where we are inflating. So we saw some catastrophes by overinflating the balloons and whatever. So just we on the roadmap we inflate and we deflate the balloon in order to see how the loop reacts with the balloon. Once it reacts and it enters inside, so 2-3 times, and that's it.
You use a 1 cc syringe or a 3 cc syringe?
Always. I never use 1 cc syringe. Never 3 cc syringe, because you know the pressure is higher with the 3 cc syringe. And you can feel progressively your balloon inflated, because with the 1 cc you can inject very quickly. So there is no resistance, and here you can rupture. Even for remodeling technique for the balloons, or when we are injecting glue or whatever, please don't inject with a 1 cc syringe. So 3 cc syringe, even with glue. So we have got a catastrophe in France recently, less than 1 year. A guy who was injecting through a microcatheter glue in a basilar artery in a AVM and the posterior circulation AVM, and he had got a rupture, and he was using a 1 cc syringe. He was condemned not because of the indication of the procedure, because it was very well indicated, but because he was using a 1 cc syringe and the microcatheter rupture. So perhaps with the 3 cc you can get it. But the practice now is to go through the 3 cc because you can feel your resistance. With the 1 cc you cannot. And he was condemned because he was using the 1 cc, which is not the rule right now.
Fantastic. Thank you.
Thank
Any more questions from the audience? Okay, if there are no questions, we will move on to the next talk by Raj Srinivas Parthasarathi and Dr. Vipul Gupta.
Okay. So we're going to go through some retrieval techniques. And so what are we going to retrieve? So we'll be retrieving coils, stents, wires. And what are we going to use? We're going to use a snare, a stent, and in case with balloon. So the case one is a snare retrieval of a coil. So this is here, you see a right pecom aneurysm. It is bilobed. You see the larger lobe has a small neck, whereas the smaller lobule has a broad-based neck. The coiling of the larger lobule went without any problems, but after detaching the coil in the smaller lobule, it migrated into the MCA bifurcation. At this point, what do? We want to retrieve the coil, so we tried to take a 021 microcatheter over a wire, and what we noticed was while we are trying to go beyond the coil migrated further. So we are taking the microcatheter beyond the coil with a preferably a synchro microwire, and then you take a 2 millimeter snare, open the loop of the snare, try to catch hold of part of the coil, and then close the loop, and then you can retrieve the coil out. So what are the issues? The most common issue that you face here would be distal migration of the coil, particularly when you're trying to cross with the microcatheter. So you try to carefully take it across, preferable to use a synchro because it would talk better. And some of the precautions you can take is, again, as I said, take the wire very carefully, and we use a 2 millimeter snare, and we increase the heparinization to avoid clot formation. So the next technique we'll be describing is the balloon grasp technique. So this is a patient who had a ruptured right MCA bifurcation aneurysm. We are using a balloon assisted coiling. The third coil was successfully deployed and detached, and now we are trying to put in the fourth coil. Unfortunately, we were not able to push the coil outside of the microcatheter, neither we were able to retrieve the coil. And this is what we thought had happened. So this is the third coil. We thought after detachment, the tip of the coil is within the microcatheter tip. And now we are pushing the fourth coil through the microcatheter, and it all got jammed up here. So it got stuck there, and because of that, we couldn't push the fourth coil out, neither we were able to retrieve it. So at this point, what to do? We are left with no choice other than pulling out the microcatheter out. So that is what we did. So we clearly know that the grasp onto the coil, the third coil that was deployed, is very, very poor. And when we're trying to pull the microcatheter out, this is what happened. So this is the tip of the guiding catheter, and you see the coil hanging loosely in the parent artery, and part of the coil is within the guiding tip. So at this point, we thought, let us try this technique, but there are some downsides for that. So if you consider this to be the guiding catheter, we know part of the coil, the previous coil, is hanging in the parent artery, and part of it is within the guiding tip. So we have a balloon in place. So what we did was, we brought the balloon back, inflated the balloon within the tip of the guiding catheter. So now we thought that we have a hold onto the coil, and we can retrieve the coil by pulling the guiding back, and that's what we did. So if you see here, this is the balloon that has been inflated within the guiding catheter, and we are trying to pull it out. So this is what happened. I hope the video plays. So here the balloon is inflated. This is the guiding tip there. You see the coil being retrieved out, but after some time, the grasp onto the coil is lost. And this is something that is going to happen because only a very small portion of the coil is within the guiding tip. And then we have to come up with some innovation or some modification to the technique. At this point, we thought this is not going to work. Probably a snare would also not work because there are a lot of coil loops in the parent artery, which is a larger artery. So one of the things we shouldn't probably have done is take a run here, because once we have taken the run, most of the coils had migrated further and it has gone and lodged into the bifurcation there. And this is a little bit more tricky situation. So what we did was, we took a Prowler Select microcatheter into the superior division, we deployed the solitaire there, and we tried to close the solitaire again in an attempt to catch hold of the coil. But that didn't work. So in bifurcation, where the coil gets lodged into a bifurcation, you can try this technique, which is called as the open and grasp technique. And this is a line out. So you know, this is the coil that is at the bifurcation. Now what you do is, you open up the solitaire. We generally use a 4 by 40 millimeter snare, a solitaire. So you open the solitaire and then push the solitaire, the open solitaire, forward in an attempt to engage the prolapsed coil. Once it has engaged, you close the solitaire in an attempt to grasp hold of the coil. And once that is done, you can pull the microcatheter out. And that is what we do here. So if you see here, this is the Prowler microcatheter tip, O21 catheter. We have deployed the solitaire here. And this is a video that would demonstrate that. So if you see here, the solitaire is open. This is the Prowler. And we're now pushing the whole system forward in an attempt to engage the coil. And then we are now closing the solitaire to grab hold of the coil. And then we are pulling the microcatheter along with the coil out. and this worked out well. So we were able to retrieve the entire coil out. And at the end of the procedure, we were able to complete the balloon-assisted coiling. So the important thing is the balloon grasp may not work if only a small portion of the coil is in the guiding tip, because it is not going to give a good grasp onto the coil. Then we discussed another technique wherein we deployed, it's a sidewall engagement with the solitaire, which didn't work either. And then we went to the open and grasp technique, which is preferable in bifurcation, where the coil is lodged in the bifurcation. So I'll describe the sidewall engagement, which worked in another case. This is a patient where we're doing a diagnostic angiography, and this is what we see. This is a case where your heart stops for a minute. So you see the aneurysm actively bleeding. So we take a guiding catheter up, we reduce the blood pressure, reverse the heparin, and we put in the first coil. So then the second coil, we're trying to push the coil. Part of the coil is deployed within the sac, and the rest of the coil wouldn't really go. There was a lot of resistance. We were trying to push and pull. It didn't work. So then we had to retrieve the microcatheter out with the coil. But partway through, what happened was the coil detached, and part of the coil is in the parent artery. One of the things, at this point, the caliber of the artery is big. So 4 millimeter. At this point, if you need to use a snare, you need to use a larger snare, a 4 millimeter snare, which we didn't have in our lab and wasn't made available to us. So we have a 2 millimeter snare, which will work for smaller arteries, but not for larger arteries. So at this point, we did the sidewall engagement. If you know solitaire, the device is a foldable design. So what you do is, this is a line out. So this is the coil that has prolapsed or migrated prolapsed into the parent artery. You go cross with the wire, take the Prowler microcatheter across, deploy the solitaire, and then sort of close the solitaire with an attempt to engage the coil and get a grasp onto the coil. And this is what we did. If you see the solitaire that is opened up, this is the Prowler, then you close the solitaire with an attempt to engage the coil. So this is what we do, and we were able to retrieve the coil in this instance. So if the coil is not at the bifurcation, potentially this is a technique that would be useful, but at bifurcations we feel that you open and advance it further to engage the coil. So there's one technique which Dr. Munayar had already discussed. It's a stent gel technique. This is an ACOM aneurysm, ruptured aneurysm, wherein we had deployed the first coil, detached. You see part of the coil has prolapsed into the parent artery. Only a few loops into the aneurysm sac, which is holding the aneurysm in place, the coil in place. So what we did was take a Prowler beyond the aneurysm, and then we deployed the solitaire so that this will prevent further collapse of the coil. And then we took a microcatheter into the aneurysm sac, completed the coiling, but we know there is a potential that this coil can migrate too. So what we did is we deployed the solitaire and detached it. So this is a technique that can be used to prevent further migration of coils. In two cases, we had to remove stents, and this is a technique that we had published as well. And this is a deploy and engage technique. This was used in 2-stroke patients, however, we thought we'll discuss it here. This is a patient who had an acute stroke with left MCA occlusion and ACA occlusion. Left MCA was opened up with a single pass. The ACA, we know, you see here the solitaire is deployed, the distal tip, and this is the wire of the solitaire. You can see antegrade flow. And when we retrieve the solitaire, this is what we notice. This is a detachable solitaire, the previous generation one. If you see the distal tip of the, this distal markers of the solitaire there, and you see the proximal marker. So the stent got detached. This is a patient who had tortuous ICA, and this is something we can see, and the wire is not there. So in these circumstances, in the past, we would have used a 4 millimeter snare. But believe me that the 4 millimeter snare, it is going to be difficult to engage this part because it's against the wall of the artery, and it probably will not be helpful. So this is what we did. Again, you open up the solitaire, either within the previously detached stent or just proximal to it, and advance the whole system forward with an attempt to engage the detached stent. You close this stent and then pull the whole system out. And that is what we did. If you see here in the video, this is the detached stent. This is this new stent that we had opened. We have engaged the detached stent. If you see, that is the proximal marker of the detached stent in between, and we pull the whole system out. And there's another video, which for time reasons I'm not showing. So, and we have been able to achieve complete opening of the MCN and anterior cerebral artery. So this may not work again because the grasp onto the detached stent may not be as good. And in these instances, we use what is called as a loop and snare technique, which Dr. Henkes had described earlier on yesterday. So I'll just go over the line art for that, so for people to understand. So consider this is the internal carotid artery. And so this is the detached soliter. As I said, a snare may not be in a good position to hold on to this, because this is against the wall. It has to go over the detached soliter, and it doesn't really do that. So what we do is we take a small profile microcatheter. As Dr. Henkes had mentioned, you can take a marathon. In this case, we used an echelon 10. We curve the tip of the microcatheter. So what we do is you take the microcatheter within the detached soliter. Once it's within the detached soliter, again you can use a smaller profile microwire. You try to take the microwire through the cell of the soliter, detached soliter, and bring it back into the parent artery. Once it's in the parent artery, now you can use a snare because you have better control. You direct the wire into the loop of the snare, you snare the wire, and you take the whole system out. And that's what we did. So this is a patient who had an acute stroke, left MC occlusion. You see the soliter got detached. The proximal end is over here. Again, what we did was we took the microcatheter. This is the microcatheter, which is going. It is looping within the stent. It has made a loop, and we have taken the wire through the cell back into the parent artery. And if you see, we have taken a snare. We have been able to guide this wire into the loop of the snare the wire, and we took the whole system out. If you notice here, this is the microcatheter that has gone through the cell of the soliter, and then this is the microwire at the tip, the loop of the microwire, and this is the loop of the snare. So this is a technique which will give a better hold on to the detached soliter, as compared to the previous one, that is the deploy and engage technique. So there's another technique that Prof. Rene Chapeau had described in the past, which I'll describe it for the purposes of completion of stent retrievals. This is a snare and stent-based retrieval. What you do here is you make the setup outside ex vivo. You see here, there are two catheters here. So this is the Prowler O21 catheter with the loop of the snare. You usually use a 4 mm snare again here. You have taken another catheter through the loop of the snare, and this is done ex vivo. And then you take the whole system into the body. Okay, so this is a soliter that has detached, or any other stent that is there. And then you have taken this is the stent delivery microcatheter. If you see here, this is the another microcatheter with the snare. So now you deploy the soliter, engage this stent that is there. Once you have engaged, you resheath it with an attempt to grab hold of the stent. Once that is done, you open up the loop of the snare, you take it forwards, and again close it. So it is a double sort of grasp onto that detached stent, and you pull the whole system out, and this does work. And just the last two techniques that we have described is snare retrieval of wire. This is a case wherein we are deploying a pipeline device. Everything goes well, but at the end, we notice that the distal wire of the pipeline got detached. So here, what we did was we carefully take a wire and prowler across. We just have to be very cautious so that the wire doesn't go further. So if you see here, we have taken it across there. We have opened up the loop of the snare, and then we carefully bring the snare to the proximal end. We can easily snare it at that point, but then it will make a loop in the artery, and it can potentially damage the artery. So what we do is we bring it at the proximal end, and you close the loop at this point and pull the whole thing out. And this can be done. Sometimes this may not work. As I said, in larger arteries you need 4 millimeter snare, small arteries 2 millimeter snare will work. So here we were able to remove the wire. Another patient, here the snare would potentially not work, so we have to use a stent to retrieve the wire. So this is a patient, we have taken a traxus wire, and this got fractured in the V2 segment of the vertebral artery. Again, this geometry or the anatomy is unfavorable for a snare and even for a stent to pull it out. So what we have done is taken this guiding catheter there, we went up, we deployed a solitaire, we are trying to resheath it, but we have tried it a few times, but it would not engage the wire. So we thought, well, let's go ahead with the procedure. It is not causing any flow obstruction. But as we did it, what we noticed is we have taken the, as we are trying to go beyond the wire migrated further. And at this point, it gave us a favorable position to engage the wire. So now what we did was we deployed the solitaire and then resheathed it, and you see the tip of the micro wire that was detached into the Prowler Select, and then we were able to retrieve the wire. Thank you.
Very good presentation, Raj. Various techniques when we are really lost during the procedure. Any questions from the audience? One little question, Raj, if you can answer. When you put that stent inside a stent and then put a snare, amplat snare, to grab the previous stent, how easy and how difficult it is?
So what we basically did was, I think it was an echelon, that case, and solitaire has got big holes. So we just struggled for a while, and it's hit and trial. You're not seeing the struts there. Wherever you see more obstruction, that is where you're engaging struts, and you go through the wire that. And then catching the wire tip with snare is very easy, because wire you can talk.
Yeah, about the other technique where you have a stent lost, you put another stent to grab it, and then you put amplats.
No. There are two cases. In one, we just opened a solitaire proximally and pushed it ahead, and you close it. So there's nothing much to it actually.
Mm-hmm.
So you want the loop and snare?
Loop and snare, no?
Correct.
So as said, if you have to struggle for a little while, it's only that you try to take the wire across that stent, form some tricky.
Stent and stent, yes.
Stent, open stent and push it in. Okay.
Yeah, taking that loop of a snare, how easy it was.
Last one we haven't done. That's what Raja described, Professor Inish has described it. Mm-hmm. But that is basically when you think only the stent will not have enough force to take out the stent.
Correct.
I guess logically, if the snare is right over it, and once you have closed the stent, it should be easy to snare it up. I mean, only thing is in these kind of situations, you get very hassled, your mind is a mess, you don't remember the pictures.
Absolutely.
So it's very useful, like all of these cases where we retrieved, Raj was with me, and it's all right, you calm down and you think it through and you do it. But we haven't done such a case. Raj mentioned it is just from a publication he showed those pictures.
Absolutely. Fantastic learning experience.
The goal here of the stent in the stent is the fact that when you advance your snare, you have, so the big issue here is to catch the proximal part of the detached stent. So you use the second stent, you don't open it completely, you make it like a partially deployed, and so you guide your snare by the stent that you have inside, just to catch the proximal part of the previous stent. This is the goal. And there is another variant of it, by putting, instead of the stent of the solitaire, so you can put a balloon inside. And you inflate gently the balloon, and like this you push the snare, it guides the snare till the proximal part of the detached stent, and like this you can pull it back. So
yeah, makes sense. Thank you so much for the presentation, and we move on to the next session.